Hi everyone, welcome to Illum 360. Um, Today we're going to continue our discussion, which started last week on childbirth complications and CS. Last week we had the privilege of hosting three doctors with expertise in obstetrician and gynecology, and today we have. And then also we had Ines, who is a midwife expert currently pursuing her PhD at the University of Ghana and also lecturing alongside. For today, we have her again, and we have Dr. Anseng Awumboro Caesar, who is specialist obstetrician and gynecologist at the Temale Teaching Hospital. When it's his turn to talk, he would add extra information that would be of interest to you all. And then we are introducing another aspect of our discussion where counseling would be necessary because in our previous session, there were questions that required that we have some um, counselors or people with counseling background to help answer such questions. And so we also have Dr. Josiah Ando. He is a certified counselor, marriage counselor, and also family counselor, and the founder and director of Paraclete Love and Love Consultancy. And also he lectures at the Valley View University, Ghana. Hello, my guests, you are all welcome.
Thank you.
Thank you, our host.
Thank you very much.
So last week we had the opportunity to talk about stillbirth courses and stuff that was given to us by Dr. Baba Musa, and also we looked at factors that are considered prior to um, prior to recommending or prescribing CS as a means of delivery. We looked at the differences between vaginal means of delivery, and we also talked about some myths of some myths associated with CS. Towards the end of our discussion, you realize that there were a lot of interest, questions, and stuff, and we had already spent 3 hours. So we thought it wise to have a follow up session to probably look at some of the issues that came up and some of the some of the questions we received backstage um, that were that were not addressed because of the issue of time. And so today I want to once again welcome you as we dive into certain specific questions. And I'm going to start with um, Ines, and this is a practical question, right? So I got a lady who had experience of CS. The first birth was through CS, right? And she felt that the second birth was, I think, 18 months, and you have already established that 18 months after first CS, there is a possibility of having vagina means of delivery. So this lady talked about the dilation that at a point in time she had only up to 5 centimeters, and she, because of this situation, she was scared, she was panicking, and didn't really, like, was thinking about the possibility that she might end up in the situation just as the first one. So I want you to help us to understand the process of dilation and how long it should take for what might be the complete dilation, process to finish, and what it means to the expecting mother. And when you finish, I think a doc will come in with a follow up before I move to my next question. Thank you.
Okay. All right. Thank you too. And thank you for the opportunity once again. And so when we talk about dilatation in labor and delivery, it is the process by which the cervix opens to be able to accommodate the part of the baby that is leading to come out. And then eventually the whole baby comes out. So I use the word the part of the baby that is leading because it's not all the time that you get the head coming first. And so there are times that the baby is not leading with the head, and we still allow for vaginal birth to happen if all things are good to go. And so, for instance, a baby may be coming out and leading with the buttocks. And if the situations are surrounding the labor are good, we could still allow the mother to have vaginal birth. So, when we talk about dilatation, when a woman is pregnant, the cervix becomes long, and then it has a plug. It has a mucoid plug that plugs it. So when I say a mucoid, I'm referring to, you see, when you are coughing or when you have a cold, the fluid that comes out when we blow our nose, that is something like a mucoid. But in pregnancy, that mucoid becomes more thickened, and then it kind of closes or blocks the opening of the womb to be able to protect the pregnancy. So the womb, first of all, is like a balloon. Okay. Let's say the womb is
Mhm.
like a balloon, and then the mouth of the womb is like the tip of the balloon. The way when we blow air into a balloon, we hold that part of it so that the air does not escape from the balloon. Now you realize that the balloon has a body, it has a neck, and it has a mouth. Now, between the body and the external mouth of the balloon, there's this neck
Mhm.
that joins the external mouth of the balloon to the body of the balloon. So let's
Balloon.
let's just say that that is how the cervix is. So the womb is like the body of the balloon. The cervix is like the neck of the balloon, and then the vaginal opening is the external mouth of the balloon. So the cervix lies between the vagina and then the womb to join them as two organs. Now, when you are pregnant, that neck of the balloon, which is your cervix, gets filled up with thickened mucus to protect the contents of your womb from coming out. So there are situations where some women have problems with their cervix and they may end up in a miscarriage. So in a normal pregnancy, this mucoid substance will stay in the cervix until it is time for the woman to go into labor. So when the woman goes into labor, she will start having contractions, which means that the womb will squeeze and relax, squeeze and relax. And this action is just a way of allowing the contents of the womb, which is the baby, to come out. So as the womb squeezes and relaxes, there's pressure on the cervix to start opening. So, first of all, when a woman goes into labor, consistent contractions will let the cervix and then the mouth of the womb, as well as the vaginal, getting to the vaginal orifice, they would start shortening to become one opening. So we call that one effacement. So that action will happen until the mucoid plug also falls out to now allow the cervical opening to become free of any obstacle to allow the baby to come out. Now, eventually, as contractions progress, this cervix would open from 1 centimeter, then move to 2 to 3, all the way till 10 centimeters. It is at 10 centimeters that the leading part of the baby is able to come out, especially if it is the head. You need to get to 10 centimeters for the baby's head to be able to come out successfully. So, a woman may go into labor. Labor will start on a normal note. She will start contracting her womb. The cervix will start opening. It may move from 1 to 2. It may get to 3. It may get to 4. But this woman may never make it to 10 for the baby to come out. And this can be due to several reasons. It could be because she's not getting adequate contractions. Sometimes we are able to intervene, do some medical interventions, and then the contractions will pick up and then labor will progress. It could also be just the state of the cervix that the woman has naturally. It just would open to a point and wouldn't open again. And then in such cases, sometimes we intervene again, give some medications for the cervix to relax, and then it will open further. Sometimes it would not open. And sometimes too, the cervix may open all the way to 10 centimeters, but the baby's leading part may just be too big to be able to pass through the size of the woman's birth canal. So several situations contribute to this. So moving from 1 centimeters to 4 centimeters or five, depending on the jurisdiction in which you find yourself, because now evidence is saying that up to 5 centimeters is what we call, is when we start having active labor. So from
Okay.
0 to 4 or 5 is called the latent phase of labor. It's usually slow. That is when things build up gradually, and then the body also starts adjusting to the new state of being in labor. From 5 centimeters to 10 centimeters is usually referred to as active phase, tends to move quicker than the active phase. And we expect that the woman will attain certain dilatation within certain period. So dilatation from 1 to 10 is not cast in stone for every woman. Everybody's body does different things at different times. And depending on the number of children the woman has had before, that can also influence her progress. So for women who have never had a vaginal delivery, evidence says that they tend to dilate a centimeter per hour, a centimeter per hour. So it means that for a woman who is a first time vaginal birth person, she may take 10 hours from the time labor starts to the time she gets to 10 centimeters. And then evidence says that for those who have had babies per vagina before, they may do a centimeter and a half per hour. So theirs may be
Okay.
shorter, but that is still not like a guarantee. So
Mhm.
because sometimes what women even think it's labor, it's not necessarily labor. So she will come
Labor.
in, she'll say, I'm having contractions, we'll time it, it's on and off, and eventually it will go off, and then we'll
Right.
monitor, and then later she goes into an actual labor. So sometimes the whole process may even take between 18 to 24 hours, depending on what time the woman reports to the hospital, and also depending on whether she was really in labor, whether contractions were properly established, and whether her body had actually gone into this whole process of labor. So that is just a bit of a description to like give you a picture of what
Thank you.
this whole labor process is like, what dilatation means, what it means to different people, and how it affects the woman's progress. Thank you.
Thank you so much for this insightful presentation. Doc, do you have something more to add? And then the follow-up is that so until uh, an, a certified midwife or doctor makes some kind of pronunciation or some conclusion on the duration or the level of opening, there should not be any room to be scared whether you have delivered through vaginal before or not. Is that some assurance you are giving to our listeners?
Yes, so here's the thing. Like I said last week, those things don't just happen when you're in labor. That is why now the system we have for antenatal care is called focused antenatal. So when you start antenatal, depending on where you find yourself, if all things are equal, you should be seen by the same provider throughout
Mm,
pregnancy, so
okay.
that in the course of your pregnancy journey, this person is able to pick up issues if there are any, help you make decisions that would benefit you and your baby early, so that it's not when you're in labor that we are now running around. So if the person who is seeing you, the midwife or the doctor, has seen you, everything is fine, and has cleared you for vaginal delivery, when you go into labor, we have tools that we
Okay.
use to monitor labor. So
Okay.
there are tools that are developed based on evidence. So we used to have what we call the pathograph, but we've graduated to a new tool that the WHO brought called the labor care guide. So when a woman comes in labor, the first examination, which is her baseline, would advise us on where to put her on that tool. And then we use
Okay.
this tool to monitor her. We have intervals at which we check different things and we document it on this tool. And then the tool will guide you as to when to take action, when to say we have reached like the maximum time for which you should allow this woman to be in labor. So different parameters from both mother and
Okay.
baby come together to help us make a decision based on these evidence-based tools that we use to monitor the process. So together with a team, we'll sit down and say that, okay, Madam A came in labor at this time. We've monitored her till this number of hours. These are the findings we are getting. And based on the experience, the things we've learned in school and all of that, we'll come together to say, no, this labor has delayed or this labor is obstructed. We need to intervene. And then a decision is made to what to do next to make sure that this woman and her baby are fine. Yeah.
Okay. Thank you very much. I don't know if it's the problem of my internet connectivity or that of Ines, but there was some breakage. But I think that the message is well sent and very clear out there. Thank you so much for being insightful about this. And now, Doc, to you. And then when you are tackling this, following this, you can talk about um, episiotomy. Is that the correct term? Episiotomy.
Yeah.
And in that case, I want you to look at it from the perspective where some people think that it leads to enlargement of the vaginal opening even post the delivery process, and if there is any truth in this, or how that issue is not true. I mean, how is it important in the delivery process? When does it become important? And then tackle that perception as well. Thank you very much.
Okay, so I would comment a bit on the dilatation of labor before I
Mhm.
come to the substantive question.
Yes.
So
Hmm.
I think Ines has touched on most of the parts, but because the audience is wide, it's not all facilities that are currently using the WHO labor guide protocol. Majority are still using the pathograph, which is just a graphical tool on which all assessment of baby, mother, the process of labor are documented on a single sheet over a period of time, so that at a glance everyone is able to tell whether labor is progressing as it should or not. Because on the pathograph, the first thing is usually to document the demographics of the patient, at least the ID, when she reported, whether she had ruptured membranes or not, among others. Then, when you come to the fetal component, this one is a graph that allows you to document the heartbeat of the baby as you are monitoring the progress of labor. And we have two broad dark lines that would usually tell us the limits of the normal heartbeat of a baby. So in our jurisdiction, we use 120 as the lower limit, all the way to 160. So any heartbeat above or below 120 or 160 respectively, our attention is drawn that there is a problem with the baby. Other parameters pertaining to whether she has ruptured her membranes or not are all documented onto it, as well as the state of the presenting head of the baby. There are other components that would now talk about the cervix in terms of whether she is even fit to be put on that tool, the pathograph. And we usually would administer it when the woman has gone into labor and has dilated from 0 to 4 centimeters. We'd also document how low the head is. Sometimes you can have a woman laboring, but the head is still high up. So all those are documented, as well as the number of contractions the woman has in 10 minutes and for how long it lasts. All these are documented on the pattern graph. So I won't go through everything, as Ines has mentioned that dilatation of the cervix usually would is expected to occur during labor when there are adequate contractions. Then the cervix would shorten progressively and then open alongside. So from a closed cervix, when you are not yet in your ninth month or you are not yet due, to prevent infection from moving from the upper vagina into the baby, where the baby is, that's the womb. That's where she said the mucus plug usually blocks that. But once labor starts and contractions begin, that mucus gets dislodged, and then you have the dilatation, that's the opening of the mouth of the womb now occurring. Then the part of the baby that is presenting would move from a high level down into through the mother's pelvis all the way out when she is fully dilated. On the substantive question, what is episiotomy? The term looks big, but it's a procedure that is usually carried out. So it's a medical procedure, so it should be carried out by a medical professional, either a midwife or a doctor, when a woman is in labor, with the aim of what? Widening the opening of the vagina to aid in vaginal delivery. So it means that a cut is usually performed, or a cut is made on the opening of the vagina to allow it to widen up to be able to accommodate the head of the baby. And we don't just do it routinely. It's not every woman presenting to the antenatal, presenting in labor, sorry, who would require an episiotomy. There are usually indications for performing an episiotomy. For instance, if the perineum, that is when a woman lies down on her back and you take a view or you look between her thighs, the opening where the baby is supposed to come out all the way towards where the anus is, that is what we call the perineum. So usually you will see that it stretches and thins out. When you evaluate the head of the baby and how stretched it is, if you feel that it is threatening to tear, you would have to intervene. That's why we say threatening to gape. You would not want a woman to have a spontaneous tear on herself because it's usually not controlled. It can tear right from the posterior part of the vagina into her anus, and that comes with some complications, such as inability to control or hold stool or flatulence, depending on the degree to which the tear is. So, most often, when the perineum is threatening to tear, we would use the instrument that is usually a scissors, episiotomy scissors, to widen the opening, and this is to facilitate in delivery. Secondly, sometimes you have the need to perform or use an instrumentation such as a vacuum or forceps delivery. You are required in such cases to perform an episiotomy since you are passing an instrument through the vagina to help deliver the head of the baby. Okay. Then we also have other indications For instance, an extensively scarred perineum. Some females, unfortunately, undergo what we call female genital mutilation, where there is partial or complete removal of parts of her genitalia, and sometimes it leaves behind scar tissue that does not stretch to open up to allow for the head of the baby to be delivered. So, in such instances, it is good you make the incision to widen the opening to allow for the head to to come out. So these are some of the indications. And like I said, it should not be routinely done. Previously, every woman going into labor unfortunately used to have one form of episiotomy or the other. And the episiotomies are in types, but the common one we encourage is the one that is made such that after you repair, the cut is around 7 o'clock when you look at your hour arm of the clock. We do not encourage the incisions that are made or the cuts that are made right from the vaginal opening towards the anus, because for that one, with the little extension, you are going to have it extending into the anal veg, which can result in some other complications. Thank you.
Thank you very much. And the other half of my question was that how is the healing process and does it actually affect the mm, the vagina opening post delivery?
Okay, so following a cut, usually we would repair whatever cuts we have done. We use a thread, that's a suture material, in lay terms, a thread that is going to be absorbed on its own. Usually, that's what
Oh,
is recommended to neatly realign the cut edges. And we usually perform the episiotomy because when you use a scissors to cut, the edges are sharp, straight, and clean. So when you bring them back together, you are able to repair it to try and
okay,
restore the anatomy.
okay,
Following this, the woman will be put on antibiotics and then asked to perform a sit bath, not
mhm,
with hot water, because it will melt the sutures. Now, the healing, depending on everybody's healing processes, sometimes might take up to about 2 weeks to a month. It depends on the individual. Some people, unfortunately, can have their repair broken down, and sometimes it will heal mal-aligned or with a very with a scar in there. Now, once the alignment is done and the suturing is done well, most often you have the anatomy returning back to near normal, more than 99%. If it's done properly well, sometimes you are not even going to know unless you see that, oh, there's a scar there or a bit of a dimple there to tell you that um, there was a cut performed there. In instances where it gets infected or the thread melts before time, that is where you would see that it's not well aligned and becomes obvious that an incision was made there, a cut was made there. And then for such people, sometimes you don't have it returning back to its expected normal.
normal. All right. Thank you so much for the insight. Once more, I think this is quite educative. And for our listeners, if you just tune in, yes, we're talking about childbirth complications, and we have had our experts talk about dilatation and also episiotomy, which is the cut involved during delivery when in layman's term, the head of the child cannot easily come up, and it's likely to cause a tear of the mother's vagina. So the expert will intervene and cut, and that was what Dr. Anseng presented. Before I go to our counselors here, I want to give Ines the opportunity to maybe add to the episiotomy uh, question, or maybe take away or something if she has. Ines, you are muted, and if you want to talk, you can unmute. And yeah.
Yeah, I think doctor has actually um, delved so much into the episiotomy bit, and like he said, it's an incision that we make to just open up the vaginal opening to allow the baby to come out. And he mentioned the various instances where that is recommended. He also touched on the fact that it's no longer routine, so it
Mhm.
is up to the attendant, the birth attendant, the doctor or the midwife to make an assessment and to make that decision when it is necessary. I think what I would just want to add is that the bit about how it affects the birth canal or the vagina post delivery, he first of all touched on different people and how their bodies heal. And I also want to touch on the bit about adherence. So, when a woman is going home after childbirth, a woman who has had an episiotomy or has had a tear, because there are times that the attendant may anticipate that, oh, this space is enough for the baby to come out, but sometimes, depending on the force with which the woman will push the baby or the part of the baby that is sweeping the perineum as he described, a woman may end up with a tear. And so I just want to touch on the adherence bit. So we give you education on how to care for the wound. And mind you, this wound is not on your skin, like outside of your body where you are seeing it that much to a large extent. The area is not very obvious to the person with the episiotomy wound. So we advise you on how to care for the area, what to do, what not to do. Sometimes some people do adhere to it and their wound will heal nicely without them having to come back for a resuturing or anything. At other times too, some people go home and then family members, people around them also start giving them advice on what to do and what not to do, which may or may not contradict what the healthcare provider says. So sometimes some people may end up with the suture melting before the wound heals, which leads to the wound gaping or opening up, and then they would have to come back for us to reassess and re-stitch it. Usually when the stitching is done the first time, because it's fresh, you can just align the various layers of the skin and then make sure that you are doing a good job. But after some days have passed, when the wound opens up this time around, it becomes difficult to separate the various layers and suture them accordingly. So these may lead to some misalignments and then cause some issues. But it is not the episiotomy in itself, the fact that a woman had an episiotomy, that is why she will end up with an opened uh, vaginal opening or like a loose vagina or anything. I think last week too, I touched on the bit about a woman's body and the role that hormones play in a woman's body and the things that happen over the years. And the fact that whether a woman has had a child or has not had a child, whether a woman had breastfed or not, as we advance in age, the body automatically starts responding to changing hormone levels. So these are some of the things that impact a woman's body, and not the fact that a woman has had an episiotomy or not, but also how you care for the episiotomy, how the healing process happens can lead to some situations that may not be pleasant. Thank you.
Thank you very much. This is very well appreciated. And before we come to our next medical question, I want to introduce Counselor Perfect. Kuma Odro joining us all the way from, I think, Kumasi. She has years of experience in family therapy, counseling, and also, I think, yeah, he's a counseling psychologist, and he's here together with Dr. Jose Ando to also help us understand how we can leverage counseling to mitigate some of the family strives that arise out of childbirth complications, specifically CS. So, with this introduction, I'm going to dive into that aspect. Of course, from our previous discussion, even from what Dr. Caesar told us, we came to realize that, believe it or not, there are some stigmatizations attached to CS and other uh, um, childbirth issues. And one of the issues that came up was the fact that as a certain man had an interaction with our co-host, who is not present at the moment, on an issue that he married with the intention of having 5 kids, right? And they believe that when you go for CS, the maximum you can have is 4 or 3 or whatever it is. And because of this, when experts have provided um, clear instruction or prescription for CS, he was against it because in that case he will not be able to have 5 children with the wife, which consequently could result in divorce or unhappy marriage and stuff. So I'm starting with Dr. Josiah Ando. How can your activities consider some of these happenings in to present a better perspective to couple, whether it's a premarital status of the counseling process, or postmarital, or like um just targeted counseling to capture some of these happenings or complications that come into the marriage because of childbirth associated issues or related issues.
All right, thank you so much, my brother. I want to express my thanks to the earlier speakers. That was very good education, and I think it is well appreciated. For me, what we need to understand is that when it comes to childbirth, couples plan it, but you do not have control over whatever plans you have had. And it is something that every couple would need to understand. Now, for me, in my premarital counseling, I discuss childbirth with the couples and I help them to plan what they want to do. But despite your planning, you need to be told and you need to come to an understanding that childbirth is a mystery, even to the doctors. You can, for example, have two, very fertile people in a marriage, and they will be there. None of them is having any infertility issues, but they may not be able to have children. And so, before going into the marriage, you need to have that pre-understanding. You need to also understand that when it comes to matters of how the childbirth is going to turn out, whether you are going to have vaginal birth or you are going to have a cesarean section, or if it is vaginal birth, whether you would have to go through an episiotomy or not, you do not have control over any of those. And so people would have to come to that pre understanding that you don't have control over whether the children will come or not. And if they come, you do not have control over the number of children. Yes, you may have planned it, but that plan may not materialize at the end of the day. Some people even plan when it comes to the gender of the children. But we just have to understand that after we have done the work, there's nothing else that we need to do. Now the other aspects that comes in counseling with the discussion, because of the description that the medical people were given is that now when it comes to us, the other aspect is dealing with issues of trauma and post-traumatic stress disorders. Somebody goes through the pain of childbirth, whether it is vaginal birth or cesarean section, and the person is traumatized. Now, some of these traumas can just be the normal traumas in going through pain, and then you are actually traumatized. But some of them can actually degenerate into post-traumatic stress disorders, where the person is even now scared to go into childbirth. And this affects the relationship with her partner. And this is where the psychologist would have to come in to help the person overcome that kind of stress. Again, you were talking about the impact of the episiotomy, for example, on the vaginal opening. Some men would complain, oh, after the vaginal birth, X and Y has happened to my woman's opening, and I don't enjoy it the way I do. Some are misconceptions. Some may be due to the non-adherence, as the midwife has said. But generally speaking, we just have to let people understand that when we adhere and we treat the wound the way it is prescribed for us, we are generally not going to have issues with the elasticity of the vaginal opening, or even in terms of the size and all that. If there will be anything at all, it is not going to be a result of childbirth. It is going to be a result of natural processes of growth and aging and other things. So these are the things that in my preliminary remarks I would mention that relate with childbirth and the counseling profession.
Thank you, Dr. Ando, for that insightful presentation. And then I will turn to our dear sister, perfect counseling psychologist. So, from the psychologist point of view, um, again, in your practice, what do you think can be done to help in solving some of this stigmatization, trauma, and the associated complexities? And let me quickly add that you might throw light also on this, because like Dr. Ando made mention of, there are also men who psychologically have been programmed in such a way that post, and I have read and have received some feedback on this, that post the CS, the incision, the scar, it's something that I don't know how to explain it, but they don't feel comfortable with, and it makes their drive and their association, or their sexual drive and association with the woman decrease. I think it might be something more psychological, but then how do you think we can leverage counseling to support individuals that go through this situation? Yeah, perfect. You have the
Thank you
floor.
very much, and thank you very much, and thank the previous speakers also. They have really done a yeoman's job. What I like to say is, to your later question, that some men have issues or they complain of the scar from the CS, so that decrease their drive, their sexual drive, when they want to have affair with their wives. I would say that if the doctors will be there, will be frank with me, and will be frank with forthcoming with the answers, you realize that if it's performed well for you, it's difficult to even identify the scar. It will just be a thin mark. Because personally, I have had three. With all my three children, I did CS.
Okay.
And it's not
Okay.
something I opted for. Yeah, it's not something I opted for. But from the first birth, when I was trying to, I don't have the contraction, and the normal women have that. I'm having contraction, my water is, I'm seeing those signs. I don't. So the 41 week My doctor said I should come so that they induce me if I'm still not feeling any contraction and anything. So I went, the induction and everything, inducing was done. Still, it wasn't open. So they said my cervix was so close, so tight that it can't open. So they need to do CS for me because the baby was in distress. And with the other two that I did, is the same CS. But my experience is this: with the first one, because they were in haste, the doctor was in haste wanting to save me because they have tried, they have given me, they have inserted about three drugs to my private part, and still I was not dilating, and the baby was in distress. They need to rush me. So the time that he needs to take to stitch me well, it wasn't done that well. So I could feel the zigzag and all that. But with the other two and the last one, if I don't tell you, you not even see that there's a scar there. It's gone. You not even see. So it depends on the doctor who does this, who is going to do the CS for you. Some do it so well that you not see even the stitch. And now you don't even remove the thread. They will give a good word to it. I'm a layman, so when it comes to that thread, you don't. It's kind of melts into you, so you don't need to go through all that hassle. But if we're a man, this is where psychology will come in. When you come, we try to let you know that them. And with the childbirth, the body of your wife is going to change. You might not get the body as she is, as you have started now. Now she's having a flat tummy. She might be having a flat tummy. Her boobs are standing and all that. But when childbirth comes in, we have different body types. And some people, you realize that from breastfeeding, they are going to have the sagging of the breast. From childbirth, they are going to have that loose and flappy tummy. And you should not detest your wife because of that. You should not stop having sexual intimacy with your wife because of that, but rather we help them to see it as a reward, as a gift that your wife has presented to you, that you have been able to use her body to produce an offspring that looks just like the two of you, an offspring that is having your DNA, somebody who is going to live after you, a legacy. And if somebody is going through all that to give you a legacy, to make your name to be established, you should rather be glad. So we help them to see their wives in this light. So the flappy tummy will come, the fallen breast will come, but still they see it as a reward. They see it as an appreciation. They see it as a virtue, as a mark of a motherhood. So they rather see that and get more excited, and their desire goes up to be with them. And I like to say this, marriage is a journey that you take, and childbirth is one of them. And with ladies, you realize that when you have a wife and she's pregnant, I always tell my clients this: if your wife is pregnant, she is physically pregnant, but you, the man, you are mentally pregnant. So you carry the baby in your mind, what they are going to eat, how to take care of the mother, safe delivery, everything. You think about those things. So you, as the man, you need to have open communications and effective communication with your partner, because this is a woman that her body is changing. Sometimes she doesn't even understand herself. There's going to be cravings, there's going to be muscle pulls, there's going to be the vomiting and all that, and she needs you by her side. She needs you by her side to be able to help her, to hold her hands, so that she'll be able to take this journey successfully, because the emotional support is very important. If you don't give your pregnant wife this emotional support, that is where sometimes we witness the postpartum depression. We have the postpartum anxiety. We have the traumatic experiences that are associated with childbirth, that some women give birth one and they don't want to get pregnant again. So they do the permanent family planning method so that they don't get pregnant again because of the traumatic experience they went through in carrying the child and giving birth. So we help you to emotionally support your wife so that she doesn't go through this, and realize that with psychology, some are prone to psychosis, and it's a family history. So if you have a wife and you realize that she is having from her hereditary, from her history, family history, they have attached to pregnancy. Because I know clients who, when they are pregnant, you realize that they are a bit lucid. Their their sanity is not that 100%. It's because of the pregnancy. Their hormones add up so much that it affects their reasoning, their normal reasoning. So you, as the man, you need to always be near this wife. And if she's having psychosis, pregnancy brings her psychosis, the depression and the rest, this should inform you that if you want to have 4 children with her, that is your desire. But because of her condition, you should reduce that number to about 2. That is the discussion that the two of you will do. And with counseling, we empower you to make the right decisions. So when you come, we help you to know that there's this postpartum depression. Some call it baby blues, but the deeper one is the postpartum depression. Some feel it so much that they can't even breastfeed their baby. There's no milk to breastfeed their baby. Some even try to abandon their baby. Some cry a lot when the baby is crying. They can't change the babies. They feel disgust about their body is changing, they want to get into shape. Some even start exercising right after giving birth because they want to get back in shape. This is where we let the husband know that this is the time you need to give her the affirmation more. Let her know that it's a process. And no matter the changes that you are seeing in her body, you like her. If you start giving her the affirmation, helping her with her diet and with exercises that are not harmful to her health, that are not strenuous now, it's going to help her to be in shape, to take care of the baby that is breastfeeding and the other care. And you also, you have the peace that you need. And always, if you are a husband, you can't be there for your wife. We always advise, we always counsel that you get somebody who is closer when she's pregnant. You need not to leave her alone in the house. Get somebody who is close so that she can be monitored. Get somebody who is close that she can have the emotional support from. If she gives birth to you, if you don't have the time that you'll be there and they're taking care of the babies and the rest, get a nanny, get somebody who'll be coming to help so that she can get the sleep that she needs. So if the baby is crying throughout the night, don't sleep off and say that because I'm going to work, I need to rest, I need to sleep. You also need to take off the baby, feed the baby and the rest. If you are using the bottle, feed the baby and the rest, because parenting is two-way. And the lady is carrying the pregnancy, but you are carrying the pregnancy in your mind. So you communicate, you go to the antenatals with her progress, you keep check on it. Then you realize that with that, even it bonds the two of you. The
Yeah.
pregnancy is bonding the two of you. It's not rather throwing the two of you apart.
Thank you very much. You've spoken a lot and you have made a lot of sense. Recently, I think I don't know if it was during the vetting of the gender minister, there was an issue that came up that she might contemplate giving fathers paternity leave. In advanced country where I am, we do have paternity leave, and um, they the parents use it as such. But then she was trying to premise her willingness to grant the paternity leave on the back of the father being at home. And these people took it to the social media and were talking about the fact that even if their husbands or the men, even some of these people are not married, the men would not be at home. So probably it's not necessary for them to be given. But from your presentation, honestly, from your presentation, the man being involved in the pregnancy mentally and also at night waking up to do all those stuff, I don't even think that paternity, I know it's not part of the main discussion, but since your presentation brought it up, I want to just emphasize that I don't think that paternity for leave should be premised on whether the man will be in the house during the day or not. I think that there are some who genuinely would would use it to support their wives, and some who might not. Of course, you know, there is always the extreme aspect. So I thank you so much for shedding this light on this aspect. I will come back again to the counseling aspect, but for now, let me take one of the most crucial uh question in the space of medicine, and that is external. Let me get my pronunciations right. I don't want to. Yeah, about external cephalic version. I'm not going to speak too much about it because we have the experts here. What is it? Is it something that is practiced in Ghana often? What is required to do that? I mean, on the part of the practitioners, what do they need to be able to do, or to ensure external cephalic version? And I mean, try to explain it to our audience as well. I will start with Dr. Ansing, and then I will move on to Ines on the same topic. Doc, you are muted, so we can't hear you.
Am I clear now?
Yes, please, you are very clear.
Yes. So external cephalic version, we also call it ECV. It's a procedure that is usually done when a woman has a breech presentation. So ideally, when you are pregnant, the baby usually floats within the water and then keeps turning, somersaulting here and there. But towards your second, third trimester, baby usually would assume a particular uh, position, or baby would usually present either with the head, which is the expected or normal, and then in other times too, you can have it presenting with the buttocks or the breech. We have various types of breech. So when a mother is told in the third trimester that the baby is coming with the buttocks, the procedure we can avail to the woman is called the external cephalic version, where we are abdominally going to maneuver the baby through an abdominal massage to try and turn the baby from presenting with the buttocks to having the head presenting downward as expected. So initially, baby is coming with the buttocks, but through that maneuver, baby now has the buttocks coming upwards and then the head presenting downward, so that when labor sets in, she can acquire a normal vaginal delivery with the head presenting. So that is what we call external cephalic version. And most often, we offer it to first timers when they are about 36 weeks, and then to those who have delivered before when they are about 37 weeks through. The reason is that you don't want to perform the maneuver too early, such that baby will revert back to the bridge position. And you don't want to also perform the maneuver too late or attempt the maneuver too late where labor had set in. Because when labor sets in and the presenting part goes into the maternal pelvic bone, it usually makes the procedure much difficult, or the chances of it succeeding would not be achieved. So the goal of performing the procedure is mainly to increase the chances of having a normal vaginal delivery with the baby presenting with the head.
Hmm.
And most often, when you have baby presenting with the buttocks, it's associated with a lot of complications to the newborn baby, especially
Oh.
when the provider does not have the expertise or the experience to perform assisted maneuvers to help
Hmm.
achieve a normal baby. Now, aside or some of the indications, let's look at some. When would you want to do an external cephalic version? So most often it should be a bridge presentation, and the baby should be one. There shouldn't be two. It shouldn't be that of twins or triplets. When there are many like that, you cannot independently rotate all of them to the right position without causing any trauma. So you would not want to do it for those who are having twins or high order pregnancies. Like I said, most often want to do it between 36, 37 weeks. And we usually would also look at the weight of the baby. We will not perform it for a child, or I mean a baby that is less than 2.5, because it's too tiny. The chances that it will rotate back to the buttocks presentation is high. And we will not want to do it on babies that are also big. Now, sometimes there are some women who will come with a bridge presentation and ask you to perform the external cephalic version so that she can try vaginal delivery. But there are some contraindications. There are sometimes when, I mean, you cannot successfully, or you should not even attempt to try to turn the baby. For instance, if the woman has a low lying placenta, so the placenta is lying at the path passageway through which the baby has to come out. So anytime the presenting part wants to pass through the cervix, there's a blockage because the placenta is low. That's what we call previa. In other instances, sometimes you have your womb not being, uh, it has abnormalities. We have different forms of uterine abnormalities. And depending on the type you have, it's not everyone who has the usual pear-shaped uterus. Some other women have different shapes of their uteri that would contraindicate performing the procedure. Then, if you've had previous cesarean sections or fibroid removal, myomectomy, some of these uterine scars increases the chance of you having complications. So sometimes they are either classified as absolute or relative, but they are also contraindications. So if it's relative and you don't want to take the risk, you can just tell the client that because of your scar, I don't want to try turning, because if there's any problem, the weaker part where the scar is would usually tear, what we call a rupture. Now, if the baby too is not achieving its growth potential, the number of uh, kilograms or grams the baby is supposed to achieve at a particular gestation, if the baby is not achieving that, what we call intrauterine growth restriction, you will not want to go and stress a baby that is already struggling in utero. Likewise, if a baby is very big, more than 3.7 to above, I mean, and above, usually the chances of succeeding is low. So for external cephalic, when it's even more than 3.5, you, the provider, you know that you are not likely to uh, have a successful cephalic version. Now, every procedure has a potential complication. So you need to let the woman know that before you perform external cephalic version, she should have been mentally ready for an emergency cesarean section should uh, a complication arise. Some of the complications could be that the baby's heartbeat could start going too high or too low, what we call fetal distress. In other times, you can have the woman begin to bleed. She can start bleeding from the genital tract, either due to separation of the placenta because you are manually rotating the baby. Sometimes you can traumatize the placenta and she will start to bleed. Other times too, the uterus can develop a tear, what we call a uterine rupture. So all these are like emergencies that you need to intervene to save the baby as well as the mother. But in most instances, external cephalic version is able to provide about 50 to 60% success rates. That is, if you have 100 women who are all breech, external cephalic version would succeed in about 50 to 60 of them on the average. So this is what I have to say about external cephalic version. And it's readily available in Ghana. I'm in Tamale here. I mean, we have the capacity to perform it in Tamale here. In other centers in Accra, I know my colleagues are there. We've been trained to provide. So what I know is that most of the specialist obstetrician gynecologists do have the training to perform it. The question is that if you are performing it, sometimes you need assistance. So, for instance, if you are in a private facility and you are the only specialist available and you haven't trained other people to assist, sometimes you need one person to be performing the rotation whilst another person is scanning just to be sure that the heartbeat is still fine. And sometimes even the maneuvers you require two people. So where you find yourself in a place that you are alone, it is not ideal to do it there so that you don't run into unnecessary complications. Thank you.
Thank you very much. On the same topic, actually, you helped a lot because I was going to ask follow up, which you have cleared. For example, if this is a possibility to allow for vaginal nerve delivery, then would CS be necessary? But you captured all of them in your presentation, which is quite great. And so I'm winding up on the medical questions, and then I will come back to my counselors here for let's say a possible case study and see how they can help in such instance. So, Ines, do you have any addition to this external cephalic version? You are muted, so yeah. Mhm.
Yeah, I don't think I have anything to add. It's actually a procedure reserved for the specialist obstetricians. And
Okay.
maybe the only thing I want to add is that if you ever want to perform this, you should ensure that you're in a facility where you have a theater on standby, so that if any of the complications that are likely to arise do arise, you are covered and you can quickly move the woman to theater and deliver the baby.
Mm.
So, aside that, I think doctor has touched on everything that there is to know about external cephalic version. Thank you.
Yeah, then okay, so now let me just weight this one into the question. Maybe it's a twofold question. And
Sure.
there is a young woman of, let's say, 26 years old.
Mhm.
Um, at few instances, maybe her BP was a little bit on the high side, let's say 130, the uh, upper reading was about 130 or above, a little bit above, and she was put on, let's say, aspirin and all that. And for several weeks consistently, she's been having 120, 123 and stuff. And the doctor says that for her age, that is still a higher BP. And maybe from the layman's point of view, it's it's a normal range of BP, right? Yeah, you say 123, 180, or 120, 72, or whatever it is. So, why would such a conceived normal range of BP be considered by a gynecologist and obstetrician as not normal for that age? I think the doc would also help in this. And for my counselors here, you can think about this question after, sorry, as they prepare to answer this, you can think about overall, what should be. Do you think that we should introduce this counseling session? I don't know if in the medical facilities they have this as a standard practice where they also bring counselors on board to support in the event that there are complications and that is going to affect affect the the family in a way that the husbands or the even even parents are thinking that their daughters, if they are not pushing, they are not doing great job and stuff. Is it a normal practice in the hospital that you have counseling and stuff? But that will go to the counselors. But for my question, it's about the BP, and there is an aspect of gestational diabetes, how it can complicate the birth situation, and what you advise for pregnant mothers or people who are intending to get pregnant along the line.
All right. Okay. So, thank you once again. You mentioned about the person's blood pressure readings, and you mentioned about the fact that in to somebody that may be like the normal blood pressure reading. Now we have what we call everybody's baseline. So I think in my previous delivery, I said something that when a woman starts antenatal, the first visit is a time to establish her baselines. So, as individuals, we all have our baseline blood pressure readings or vital signs. And these baselines are usually established at times when our body is not in any form of compromise. So, even when a woman is reporting to you for the first time pregnant, that is not a time that she's not entirely not compromised, but early pregnancy is usually a safe space to establish a baseline when you are seeing her for the first time. So the doctor may be telling this woman that even though your blood pressure is around a range that may be considered normal for another person, because of your baseline that we had when we first saw you, we are beginning to get worried. So some people naturally would have a low blood pressure. For instance, personally, my upper blood pressure, what we call the systolic, my blood pressure will never go above 110. So that's my
Wow.
baseline. Yes. And we describe, or we um, let's say we describe high blood pressure or hypertension as a change in blood pressure of a systolic of 30 millimeter of mercury and above, or 15 millimeter of mercury for the lower one, the diastolic, and above. So if my baseline blood pressure is usually around 90 over 50, when I start reading 120 over maybe 85, my doctor should start getting worried. And
Okay.
so, based on that, the doctor will do other assessments, check my urine to see if there are any proteins getting into my urine. There are other things that the doctor can request for other blood tests to see what exactly is happening to other organs in my body to see if there's a need to put me on medication. And so that's why we say that care or healthcare is individual. So what works for one person may not work for another person. And especially when a woman is pregnant, that we can't take chances. It is important that those baselines are established early, especially in the first trimester when a lot hasn't happened yet, so that if there's any change subsequently, the doctor can quickly pick it up and intervene. So that's why we always advise people that your healthcare provider knows best what they are saying. If you have any doubt, you ask questions. If you have further doubts, you seek a second opinion instead of relying on maybe the things we read online, because random Google search may give you a lot of information, some of which may not necessarily be credible. And so if you feel that you have problems with a particular provider, you can seek a second opinion, maybe from a different provider in the same facility, or in a different facility that has maybe higher status compared to the one you are working in. So to say that somebody has hypertension, you always need to compare what you are getting subsequently to what you got at baseline. And I don't think the diagnosis will be made just on a one-off check. Maybe it was on multiple checks and other things have been done, and the doctor thinks that where we are heading to may not be safe. We need to put you on medication. I know where we come from culturally, some of these things, when we say it, then we get a bit jittery, but it's important to ask questions, seek clarifications, get a second opinion if you feel uncomfortable. And usually hypertension tends to coexist with diabetes, even though they can still exist independently as two different situations. So
Hmm.
sometimes a woman may not have hypertension but can have pregnancy induced diabetes. Sometimes it is not even pregnancy induced, because we don't do a lot of checkup in our
Checkup.
part of the world. This
Good.
condition may already be there hiding in your system, but because pregnancy now requires you to go to the hospital often, then it is picked up and we think that it is pregnancy induced. And there is also a way that we are able to tell if it is a pre existing condition or if it is pregnancy induced. And there are checks to be able to tell when you should be put on medication, when you should be on admission to be monitored further, when it is even dangerous to allow the pregnancy to continue. And so baby needs to be delivered earlier than normal. So when it comes to things like hypertension, diabetes, one size does not fit all. So the kind of care or the kind of things the doctor will request, the midwife will request, will differ from person A to person B. The most important thing is to listen to what your provider says, adhere to it. If you feel uncomfortable, you ask questions. If you think you are not convinced, you get a second opinion. Thank you.
Thank you very much. And thank you very much again. I like an aspect of what you keep emphasizing. If you are not convinced, ask questions and all that. You know, you are speaking and emphasizing this because you are an expert, and you know that if this is not what I'm expecting, and my doctor or my expert is telling me, then I can ask questions. But there are people who don't know. You know,
Yeah.
it's like I know that, for example, I'm asking this question because I know that at least for a certain range of readings, it should be normal, in
Yes.
quote. But
Yes.
this is what the doctor is saying. And I was there when she was telling this to the person. So I just
Yeah.
negate, and but the person couldn't even ask anything why and stuff. But it's really important to understand, because if you come to me, who has read and know that this is a normal uh, range for BP, without knowing this baseline and all that, I might say probably it's not true, but you
Yeah.
have
Yeah.
clearly. And
Yes.
I am taking this initiative because there is so much misinformation. There is so
Yeah.
much information out there that you think that it's not. And when Dr. Caesar mentioned that they do the external cephalic version here and all that,
You're
it sound
surprised.
it yes. Exactly. I was surprised. It may sound like you don't hear about it, and all you hear about is CS and all that. But this has been quite insightful engagement, and I really appreciate your contributions and dedication to getting
Great.
our people informed.
There's just something I want to say over here, because we have a wide range of audience. You see, to do cesarean session in Ghana, our cesarean sessions are audited. So you
Mm,
don't just get up, and as much as people assume that, oh, we think is the easier way out, people just rush people to theater. Cesarean sessions are audited.
mm,
Questions are asked. We have what we call maternal health audits. And maternal health is something that every country takes very serious. So maternal health audits, questions are asked. Why is it that hospital A, your cesarean section rates are high? What are the indications? Why are you people doing cesarean sections? Why did you do cesarean sections for Madam A, B, C? And we answer questions. When we lose a
true.
woman, unfortunately, through childbirth, see, it's not a joke. The things that healthcare provide, it's like you are facing a Sahindrin. You need to justify that you did everything that you were supposed to do by the books, and things just happened. But we don't just do things just because we feel like doing it. Everything you do is either audited even by your peers, the people you work with, the people you work with, who ask questions, because we work in shifts. somebody takes her from somebody, somebody hands over to another person. So even your colleagues will ask you, why did you do intervention A, B, or C? And beyond that, we also get audited as teams, as a facility. So people don't just throw interventions around. And now the push is even towards allowing labor to take its natural course as best as we can without a lot of intervention. So, and
Mm.
I understand that sometimes our clients are a bit laid back. They don't want to ask questions, but ask questions. You have a right as a client to ask questions. If they cannot give you as much information as you want, you can seek a second opinion. Thank you.
Thank you. I ask a question is something we should push and then keep telling people, because I am coming from a place where people, you can be in a queue and one person will be with the attendant and they will spend hours there and you are waiting. They need their questions to be answered. So we need to ask questions that will get us the right answers. Doc, please, about the same questions or topic, any opinion or information to share?
Okay, thank you. So about the BP, high blood pressure scenario you shared. So what we have to know is that everyone has a baseline, as Ines did mention, but most often, if your blood pressure starts to rise per the parameter she gave, your index of suspicion should start to rise. But to be able to say that someone has um, hypertension in pregnancy, WHO would or usually pegs it at a systolic. That's the upper value being 140 and the lower value being 90. And
Okay.
there are different classifications of high blood pressure in pregnancy. We have
Mhm.
some people who, prior to getting pregnant, already have high blood pressure. So when they carry that into pregnancy, we would term that chronic hypertension in pregnancy. So
Okay.
for such people, the key thing there is that the medications you are on prior to getting pregnant, we might need to change them because most of them have a deleterious effect on the unborn baby.
Baby.
That's one thing patients should know. So as soon as you detect you are pregnant, you need to go in for your doctor to review your medications and then change them to those that are suitable for pregnancy. Then we have those who would move from chronic and start producing or leaking proteins in their urine when you test or send their urine sample to the lab. So they are those we say they have chronic hypertension with superimposed preeclampsia. Now, one thing about hypertension you should realize is that it is a progressive disorder in pregnancy. So some other people would previously not have high blood pressure, previously not be leaking proteins. Then, when they get to about 20 weeks or about 5 months through their pregnancy, their blood pressure starts to shoot up. They are those we call gestational hypertensives.
Okay.
And the 20 weeks is because in your body, there are some changes that occur that sometimes predispose a woman to having uh, problems with at the placental level. The problem about hypertension that occurs in pregnancy is a placental disease. So when the placentation does not occur as it should, then you have the high blood pressure occurring. So irrespective of whether you had pre BP before pregnancy or during pregnancy, what you should realize is that it has to be managed. The BPs have to be controlled with medications that are not harmful to the baby and to the mother. And then we have to deliver at appropriate times. When I say deliver, sometimes your blood pressure is so high that we cannot wait for you to get to your ninth month or
Oh,
37 weeks. And the blood pressure, just like in the normal population, can affect all body organs or systems. So you can develop eyesight problems, you can have a stroke, you can have kidney shutdown, it can affect your baby, among others. So when the doctor says that your blood pressures are scary or very high and he needs to deliver, it is for the safety usually of the mother, irrespective of the gestational age or how old the pregnancy is. Because if you don't intervene, the mother eventually might convulse or have what we call eclampsia. Now, eclampsia is a very dangerous medical condition that most often can take away the life of a pregnant woman. So we should know that within teaching hospitals in Ghana, it is the number one cause of maternal deaths. Although the global cause of maternal death is excessive bleeding, hemorrhage. But within Ghana here, most hospitals, if you have 10 deaths occurring, about 4 to 5 are due to high blood pressure problems. So high blood pressure in pregnancy should not be treated lightly at all. In some instances, we might even have to bring the mother into the facility for as long as we are able to control the blood pressures in-house. Sometimes they will take them, they want to take the medications, but they get to the house, baby crying here, husband needs has to be done, they have to go to work. So many external factors that can impair her from taking her medications, and the blood pressures will not come down. So sometimes we have to bring them in, stabilize them, make sure the blood pressures are controlled, whilst we try to mature the baby's lungs. Because at any point in time, when the blood pressures become difficult to control, you would have to deliver. And most often, once you deliver the baby, the disease progression starts to regress, such that by 12 weeks maximum, those who acquired it during pregnancy, majority of them would return back to normal blood pressures. But those who had it before pregnancy would continue with the high blood pressure even after the 12 weeks have occurred. Likewise, the diabetes in pregnancy. I mean, when you are diagnosed, now one thing about diabetes in pregnancy is like hypertension, you can have it before you get pregnant.
Mhm.
You can also have it, but you didn't know until you were first tested. Then we have those who acquire it as a result
Mhm.
of some pregnancy hormones within the body. Depending on which classification you belong to, there are strict criteria for diagnosis. And the management, if you already had it, the chances that we will manage you on insulin injection is very high. But most often, if you acquired it during pregnancy, then oral medications can be given to control the blood sugar. But you should realize that anytime you have high blood sugar, what it means is that whatever you eat, your body does not make use of the sugar that is formed when digestion takes place. So these high levels of sugar gets to the baby, and baby would feel like dadaba. There's enough sugar in the blood. So baby keeps growing bigger than the age at which it should attain that weight. And that is what happens, and the baby gets so big such that vaginal delivery sometimes is not possible, especially when the weight gets above 4 kilograms. Yes, there are other complications that can affect the mother. So, for instance, if the mother is not compliant on taking the medications, she can start having complications that can lead to maternal death as well. So, what I would like to say is that whatever medical condition you have during pregnancy, please report to your health facility and make it a habit that as you attend antenatal care, if they haven't referred you to see a doctor, a specialist, on one of the days, plead to just have a look or get attended to by a doctor. Because
Mhm.
some facilities you have the midwife having to give you permission to see a doctor because you have one condition or the other. But there are other
Mm.
times too, certain conditions might be overlooked or missed. So I would usually advocate that although you are performing focused antenatal care, you should not have your 9 month visit without a doctor seeing you. At least try and see a doctor before you deliver. Because on the day of delivery, if there are complications, it's not nice that that is the first time a doctor has been in the facility is now seeing you. So what I would advocate is always encourage or be motivated to seek to be attended to by a doctor. Not all the time, but once a while, just let us have a look. Or now we have midwife specialists who are equally uh, trained for that purpose. So if your facility has such expertise, utilize
Mhm.
them because they have been given the extra training to be able to pick up some of these complications. Thank you.
Thank you very much. So, with our counselors here, you presented your first cases on the basis of your private practice. I don't honestly know exactly what goes on in the medical setup. If there are psychological uh, teams or counselors on board to help, because probably we have not realized how frequent or how um, deleterious these um, complications or the negative influence of these complications have on the families. But I'm asking, do you think that in your practice you can advocate for the inclusion of counseling around this topic to be integrated in the medical system, if even the government is not yet to take on the responsibility of having you as part of the medical team or practices in childbirth or maternal or maternity care. What can you as also individuals do to cooperate with hospitals or health facilities to offer your expertise to help better society and family?
Well, yeah. So ideally, it is expected that the counseling profession and the medical profession work hand in hand. Ideally, now the reason it is so is that the what I would not be able to do as a counselor is that I wouldn't be able. I don't give medicine as in orthodox medicine, but what I am doing is also healing,
Mm-hmm.
and it has to do with the emotional, the biopsychosocial aspect of the individual. That is what I am presenting. Therefore, since I mean the doctor will give the medical part, the part that has to do with the physical medicine, and we would also provide the other aspect. In fact, hospitals are supposed to have a clinical psychologist, somebody
Okay.
who would be able to um, offer help when it comes to psychological help. Now, those of us who are not clinicians, now I am not a clinician. The kind of counseling that I offer is non-clinical. It has to do with just the emotional, the psychological aspect of the individual. And when we are talking about childbirth, earlier on I talked about the issue of trauma and PSTD, PTSD, sorry, post-traumatic stress
Post traumatic
disorders.
syndrome.
I talked about, no, I think I didn't mention that, but yeah, Perfect mentioned the issue of anxiety that people will go through. The issue of body image, I think it came as part of the discussion. After childbirth, the person feels that this my body is become something that I'm not proud of, and it affects intimacy in marriages, and that is where we come in. It affects relationship dynamics. In fact, even the fact that there is even a third person in the home, the fact that there's a baby sucking on the breast that you enjoyed sucking, those things should be dealt with, and that is where we come in, emotional processing, taking decisions about childbirth and other things, ensuring that we get partners to give the necessary support when it comes to these things, and even getting back in shape, or should I maybe put it, recovering and getting back in shape, especially when it comes to your sexuality after childbirth, are things that are related. And if the doctors will actually collaborate. Now, what I would do would be, when I meet a case that would need a doctor, I will do a referral. I'll refer to the doctor. I know that the doctors get training in some form of counseling, yes, but there may be cases where a doctor would say, you know something, I am referring you to Dr. Ando. Talk to him on this issue, and as a counselor, he'll give you the necessary help and support. And that is what we need to do: collaborate together with the healthcare providers, so that we can have a completely healed world.
Thank you. Before Perfect comes in, I asked this question in particular because I feel like in our part of the world, we don't really use the counseling services that much. I don't know if that has been your observation as you are people in the practice. But when you go to the USA and other developed countries, bro, that is an integral part, and people are well informed that when they are in this situation, this is where they need to go. And government is investing heavily in mental health counseling and all those aspects, right? Psychotherapies and all that. I don't really see it here, and like you rightly said, I feel like when I'm sick, I will go to the doctor. When the doctor thinks that another aspect of my sickness is not medical related, and it's psychological, probably they directing people to seek counseling would be a way forward to help bridge the gap between people, or help get people to the right source of information that will help their general well-being.
Yeah, yeah,
Please,
yeah.
Perfect.
Sorry. The reason for that is mainly because people misunderstand the role of the counselor. In
Mm,
our part of the world, many people think that it is just advice given, which is a very wrong understanding of counseling. And so the person thinks that, well, why will I go to him to give me advice when I am even older than him? Or when I am, these are some of the reasons why people may not even patronize a counselor. But no, it is not a matter of advice given. The person has been trained to give you professional help to make your own decision on your own. I mean, at least an informed one. And that is what we need to get people to understand about counseling. Thank you.
great. Perfect, please.
Yeah.
Yeah, so I will say I would like to recommend the Ghana Health Service, because when it comes to the area of roping the husbands in with this with pregnancy, they are doing well, because you realize that when you go to antenatal, priority is given to men who comes with their wives. So if you come with your wife, they take off you earlier than the ladies who go there alone. Their queue is different from the ones who go there alone. So it encourages more of our husbands, the men, to go with their wife, because with every when you go for pregnancy lectures, they educate the women, but it's also on us as a public to take certain things serious. Some people will just want to go and take their vitals and just see the doctor and move on. They don't want to go early to listen to that lecture that is being given to the pregnant woman. So they do that, and mostly after the postnatal too, they also give precedence. They also give that advantage to men who come with their babies and all that, to make them to also be part of the pregnancy journey. And when you work with the Ghana Health Service, I work with the Ashoman Community Hospital, their mental health unit. So when you take the mental health unit of the Ghana, what they do, we realize that health is not just about the physical. The medical doctors do the physical aspect. Then when it comes to the mental aspect, mental mental is having sessions. So we have the psychiatrists. So the psychiatrists are there, they do the deep psychoanalysis and the drugs and other things that is supposed to be done. Then we have the clinical psychologists. So these people can administer drugs to you. They can also prescribe drugs for you to buy. So antidepressants, they can give you what to buy this, buy this type. For we, the counseling psychologists, ours is the talking therapy. So we do the therapy more, and we realize that the medical, the health aspects, the mental health aspects, we mostly emphasize on therapy more than the drugs because the drugs give side effects. I have clients who I realize that with their depression, it's clinical. So I refer them and they take care of them, but they need to pair the two. They need to pair the clinical, that is the taking of the drugs, with the therapy, the psychotherapy that I take them through, that the journaling, the listen to music, the exercising, the diet, and those things to help them to overcome, because it's not just the drug that is going to get them of what they are experiencing. So that aspect is there. We also work with the mental health unit. And in Ghana, I like to say that most hospitals have the mental health unit, and it comprises all of these. So if you have any challenge, you see, with Ghana, we have the institutions, but most people don't know that these are the institutions that we have, and you can work there and have your solution solved. So you can go to the mental health unit, and when they realize that it's not a clinical thing, it's not a psychiatric thing, you need a counseling psychologist, they are going to call us in. So you'll be there, they'll call you in, or people book that I need to talk, and you go, you do it with them, you give them the therapy, what they need to do, you do the follow-ups for them, and you realize that they are getting better. And we also give, we write everything as the other health professionals do. So you feel everything, their previous what they came up with, their general appearance, everything. You feel everything form, so that when the supervisors come, they know that this is what we did. The occupation, age, everything. The book is there. You feel everything. But with Ghana, as I said earlier on, most people don't know that we have these institutions. And you coming to me in my private practice as a perfect counseling network. When you come, I charge you. But when you go to the hospital, mostly health insurance even covers that for them. So you don't pay me. It's just that it's the government that gives something to me. But if you come to my private practice, I charge you. But is this, if you want that adequate, that extensive service, that follow up, that I can still follow you up, come to your house, and even 2 years, I'll still be doing the follow up and checking up on you. The private practice works more because I know that you are my client. I'm responsible for you. So I need to quite follow up. So with Ghana, I'll say that we are also doing a lot, but the information need to go out there that this is what is happening, and we have these institutions. If you need help, just walk there, and they are ready to help.
Thank you very much. I will come to you for your final words, all of you, so get prepared. And I thank you so much. I I I, I am quite informed through this engagement. On our social media platforms, I see stories upon stories, and sometimes I see people seek therapy, seek therapy, seek therapy, and that tells us how people are getting informed. And also, I think there are people who are clearly lost when it comes to seeking therapy, or the kind of situation they find themselves and where to go, just like Perfect said. So it is against this background that we are motivated to organize some of these sessions to inform people, to get people informed, to take the necessary steps and measures to better their lives holistically and not just an aspect. So I want to thank you before we even end that you spend so much time and resources. I know some of you are quite busy. For instance, Ines, PhD lecturing and maybe doing other things and taking time off all these to come. and speak to us. Last week was about 3 hours, and this today is almost 2 hours. We can't appreciate you enough, and thank you so much, Dr. Anseng and Dr. Andor, and also Counselor Perfect. But then, before we close, any final words to our listeners um, on the whole issue of childbirth complications and associated stigmatization and myths and all that? I will start with Ines. Any final words? Ines, are you with us? Okay, let's start with let's go with Dr. Hansing.
Yes.
I think I was trying to unmute and I was stuck.
But okay. Oh, okay. So now you can go ahead, please.
Yes. So thank you once again for the opportunity. It's been a great conversation, and thank you to your listeners as well. I also want to thank the counseling team. I like the fact that Counselor Perfect actually projected the part of healthcare that sometimes people may not know about. Healthcare has greatly evolved in Ghana. We now have mental health departments in almost all hospitals, including private hospitals. And when it comes to maternal mental health, this is something that we are taking very seriously. We refer women who have had miscarriages, those who lose their babies, women who are trying to conceive and are struggling to these places so that they have extra support on that journey as well. So, yes, we have these things available in Ghana. They are free in some hospitals. In the private sector, it may be part of your usual consultation. So I believe that as providers, we still have that great responsibility to continue providing education on these things, public awareness creation, so that eventually healthcare is accessible to everyone and no one is left behind. Thank you.
Thank you very much, Dr. Hansing.
Thanks for the opportunity, and I would like to say that all pregnant women um, should usually present early to the health facility as soon as they miss their periods or menses, so that they can be cared for early and follow throughout. They should seize the opportunity to ask questions. Uh, gone, gone were the days where um, many patients didn't feel confident to ask questions, and some practitioners weren't patient enough to listen and attend to the needs of patients. That trend is rapidly changing, so most caregivers now are open to all forms of questions. It's your right, and like my other speaker did mention, you have the right to ask questions pertaining to your health. Seize that opportunity. Then, as caregivers, let's usually try and look at the human being holistically. Let's not just look at the various diagnoses or what they came with. Sometimes their mood, their affect, all can reveal certain things. And the current recommendation by ACOG is that we should also ask of intimate partner violence when our pregnant women present to us. Some of them are going through a lot at home, and we should seize the opportunity to ask about some of the challenges they are having and then refer them appropriately. I've had instances, an instance where we picked up a woman who was actually suicidal, not just once, on several occasions. And she said she's been having it. She sometimes sees the ceiling fan and feels like ending it all due to some challenges. Now we have clinical psychologists in virtually all government facilities. So I referred her to see a clinical psychologist, and together we've been able to provide some assistance to her. So, take home is that interact with your health workers, be friends with your health workers with the aim of achieving more information that you require. And my colleague had health workers, if you can open up, sometimes you need to even share your contact with the person. But let the person know the rules of engagement. I give my number out freely, but I'll tell you, if you call once and I don't pick, leave a WhatsApp message or a regular message. I'll call you back later so that I'm not disturbed unnecessarily when I'm busy. So we are available to, or I'm available for any other sessions in the near future. Thank you for the opportunity. Hello, Enoch.
It looks like Enoch has left the stream. So perhaps since we are giving our last words, I would just give my last words, and because I think we are still live. So what I'll probably say at this point is that, let me speak to the men, that when women go through childbirth, there is a lot happening. Yes, we have projected the fact that the men also go through a lot by carrying the pregnancy mentally in their head, and all the other elements of support. But let us try to be empathetic towards each other, especially on the side of the men being more empathetic towards their wives, and understand that whatever she's going through comes with so many other things, hormonal changes and all that. And when the mother or the woman would have to go through the pain of childbirth, either vaginally or through cesarean section, let us give all the support that we need to give. Thank you very much. I think at this point, Perfect
Thank
can
you
give
very
her
much.
final words, and
I'm so
we
sorry.
will
I'm so
end it
sorry.
there.
I'm so
Yeah,
sorry. I'm back.
I'm delighted to be on this podcast with this elite minds. I've learned a lot from all of you, so I'm happy to be here. But I like to say this: pregnancy is not a journey for just the woman, but for the community around her. She's carrying life. She's going to give birth to a person. So we should learn to be kind around her and take her emotions into account. We should care for them emotionally if her emotional needs are met. It mostly reflects in the child and everything, the childbirth and everything. So not just the husbands alone, the society. We should be concerned about pregnant women. And I also say that if you need further counseling and counseling services, we are online. So I'm Counselor Perfect on all social media. So do link up, and if you need counseling, just take my number, call, and let's help you deal with what you are going through. Thank you.
Thank you so much, everyone. I'm so sorry my network was messing up, but thank you so much for your time and for standing in for me when my network was messing up. And hopefully, if we get some interesting topic that will benefit society and it's within your areas of expertise, we will come to you again and plan that for the greater good of society. Thank you so much, Dr. Anseng, and for Ines. I really appreciate your efforts for the two sessions we had. Thank you. And for now, I will say bye bye to you all.
Goodbye.
Bye
Bye.
bye.